Good morning, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Identifying Environmental Risk Factors for Relapse. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options have been posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option, which has also been posted in the chat panel. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through the attendance, we host an online community that provides a personalized digital journal where participants can maintain a statement of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of the registering remains confidential. Statements of credit will be posted 10 business days after the evaluation closes on Thursday, July 25th, in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, July 25th. You will not receive a certificate of completion after you have completed the evaluation. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE broker when you register with the FADA website. For the first time, if you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure of the attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenter, Monica Rosso. She is a certified health education specialist and public health professional with extensive experience in public health education, coalition building, program development and coordination, evaluation, and advocacy. Monica currently serves as the Community Engagement Coordinator for Bay Care Behavioral Health. In this role, Monica coordinates collaborative community projects to improve behavioral health in Tampa Bay and analyzes policies for their implications on community health. Before this role, Monica spearheaded the Pasco County Drug Misuse Prevention Coalition, ASAP, coordinated tobacco-free Florida programs for the Florida Department of Health in Pasco County, taught undergraduate public health courses at the University of South Florida, and served as a research associate in South Texas. Monica has her master's degree in public health and is scheduled to graduate with her doctorate degree in public health this August. And now I would like to turn the presentation over to Monica.
All right, thank you. I am just checking that everyone can hear me. I'm waiting to get the slide deck. Oh, there we go. Okay, hi everybody. Thank you for joining in on this webinar. I'm Monica Rousseau. Thank you so much for that introduction, Diane. I am very excited to be here. Like was just said, I am expected to graduate with my doctorate in August. That's actually next week. And this is the work that I've been working on for the last 2 years of the doctorate program. So this is my first time sharing this with practitioners, which of course was the goal of a project of this nature, was to be able to improve behavioral health and public health by sharing the results with the community and practitioners in the field. So I'm very excited to be here. Thank you for being here. So we'll just get started. So this is called, really, the title of the project is Roadblocks in Recovery, Identifying Environmental Risk Factors for Substance Use Disorder Relapse. So we will be going through the journey of understanding the current literature behind that topic and the project that I conducted as a doctoral student. So just to go over some of the objectives, by the end of part 1 of this presentation, attendees will be able to describe the gaps in current relapse and prevention models. By the end of part 2, attendees will be able to describe community-wide risk factors for relapse. And then by the end of part 2, attendees will have a better understanding of and be able to describe potential interventions to deploy in their local communities to reduce risk of relapse among people in recovery from substance use disorders. So obviously there is a part 1 and a part 2. We will be taking a brief break at the end of part 1 for about 5 minutes and restart again. So just a little outline for your own reference. Part 1 will really be that background information. So scope and significance of the problem, some guiding theories of relapse, current literature, and then highlighting a few of the gaps that I found trying to work in this field, gaps in practice, theory, and literature. And then part 2, we'll dive into that study that I've been working on, and we'll go over the methods, results, and spend a lot of time on implications. All right, so part 1, I always start my presentations with a story. So I think a lot of you on the webinar are probably familiar with this since it's very prevention focused. So sorry if it's redundant for some of you. I'll try and mix it up with a few different details. But this is a story that we use a lot in the field of public health. It's the upstream or downstream story. So really quickly, I would like all of you on the webinar to pretend that we are all hanging out, all 113 of us are hanging out by this river that you see in this picture. And we're having a lovely breakfast. We're really enjoying ourselves, enjoying the summer weather. Perhaps we're not actually in Florida because it's hot outside, but we're enjoying the weather nonetheless. And, you know, as we're visiting, you know, one of us notices that a child is struggling in the water. So one of us jumps in, gets the child, brings the child to the shore. The child's a little disoriented, but okay. We call her parents come get her. We're getting back to our breakfast, our lunch, and enjoying ourselves again. But at that moment, Mark notices 2 other kids coming down the river, and one of them doesn't look to be swimming. So we jump in the water again, get the kids. We have to resuscitate one of them. We called 911. We're calling the parents. Definitely a little frazzled now. And before we even get back to the lunch, we start noticing 5 kids are in the river. 10 kids are in the river. Some of them aren't swimming. Some of them are unconscious. So at this point, we have a line. We have an assembly line situation. We have one person in the water, grabbing kids as they're starting to float by, tossing them to the bank. We have several people conducting CPR. We have several people calling family members. We have people calling 911. We have people using social media to get everyone down to this river because there are kids drowning in the river, and we need everyone's help. And it's at this time that one of us just starts running up the river. Tracy just starts running up this river, and I look at her, and I'm frustrated, I'm angry, I'm in the water, I'm overwhelmed, and I scream to her, "Where are you going? What are you doing? We need you here. Don't you see all these kids in the water?" And Tracy yells back, "I'm going to go figure out why the kids are falling into the river." And so as she runs up this river, she notices that there's this dilapidated bridge. It's this really rickety, horrible bridge. There's gaps in the wood, so kids are falling through. She looks across the bridge, and there's this really amazing ice cream truck, with all this candy stuff. So kids are crossing this horrible-looking bridge to get to this ice cream truck. Some kids are taunting other kids to jump in because it looks cool, it looks fun. And so the moral of the story is that by the value of just running up the river, Tracy was able to see, man, there's so much going on here that we need to fix. One, we need to give life preservers to these kids who are already in the water so that by the time they get downstream, they'll be okay. We need to make sure that that ice cream truck is removed. This is ridiculous. What a horribly placed ice cream truck. We need to, most importantly, fix the bridge. We need to rectify the holes. We need to reinforce it. We need to put chains up or some kind of blockades up until that's done so that kids don't go and try and cross it. And so that's really the essence of public health, is that we try to work upstream as much as possible and change the environment so that we don't see people falling into the river and really struggling. So in most public health cases, like maybe diabetes or cardiovascular disease, that you can very clearly see who is in the water and who is on the shore and what the prevention work is. So a person struggling with cardiovascular disease who might be having a heart attack, they're downstream. We do AEDs, we call the ambulance, we get them into treatment. Those are downstream approaches. The upstream approaches are in public health, fixing that bridge. So making sure that people have good nutrition, people have access to good nutrition, people have safe environments in which they can play and exercise. We have that also in the substance use disorder field. We have a lot of great primary prevention, secondary prevention, and tertiary prevention work. So upstream, downstream, midstream work in the addiction world. Where I'm really fascinated is, what are we doing with people when we get them out of the river, we resuscitate them, we get them into treatment? What happens to prevent them from falling back into that river? That's really where I'm fascinated, and I'm trying to figure out how we can build communities that prevents people who are doing well from falling back into that river. And from my perspective, it's kind of hard to figure that information out. So just a little bit of the scope of the problem, which I think all of you are very well attuned to. Drug overdose is now the leading cause of accidental death in the United States. Alcohol and drug use have been credited with an unprecedented decline in life among Americans for several years in a row, which has, decreased the average lifespan of Americans. And opioid misuse alone costs the U.S. more than $500 billion annually. So, obviously a very important problem. And obviously we know that this is a priority at the national, state, and many local communities. So it's been a public health priority for a while to figure out how we can reduce addiction and its consequences. And we have on this next slide kind of a layout of what some of the solutions have been. So we're looking at that primary prevention. That's where people are fixing the bridge. And there's been quite a good amount of effort in increasing access to evidence-based curricula There's been campaigns to help people get into treatment. There's been campaigns, anti-stigma campaigns, and then there's been many measures to decrease access to drugs among youth specifically. Primary prevention has been very much focused on that youth component. Secondary prevention, so for people who are early in the river, or those kids who are early on in that river, where we might want to be tossing them life preservers. Secondary prevention in this case has been increasing expert initiatives, so screening, brief intervention, referral to treatment initiatives where we try to identify people early on for having a substance use disorder and getting them into treatment. We're working on care navigation. And then that tertiary prevention has been largely from a national and state level. Let's increase access to treatment. We must increase access to treatment. And care coordination, recovery support services to an extent, but really that access to treatment. And a lot of that effort has been on medication-assisted treatment. And for those of you who might not know, I do have a small definition down there for MAT, which is the use of FDA-approved medications in combination with behavioral therapies to help patients manage and recover from their substance use disorders. There has been some scientific call for action on how to better engage people in treatment, but really tertiary prevention at this point has been, let's just increase access. We need to increase access. So those have really been the three main areas and some of the strategies that we've been working on as a country, as a state, as local communities. And what I see really missing here is a public health approach to relapse prevention. We have recovery support services, but those services are still given to people individually. We're not necessarily investing in our communities to make them resilient to relapse like we are investing in our communities to reduce obesity. And I think that's a missing link in making our communities healthier and stronger. So given that 12-month substance use disorder relapse rates continue to exceed 60%, and only 35 to 54% of people with substance use disorders ever reach remission status, it seems pretty imperative to me to spend a lot of attention on preventing relapse. And given that not all people will want to engage in MAT, I know a lot of clinicians on this call are probably saying, yes, we know so many people who do not want to engage in MAT. And so given that, and more importantly, given that MAT is not available for all substance use disorders, it's available for opioid use disorder, it's available for alcohol use disorder, it's available for nicotine replacement, but in terms of meth and other drugs, it's not available yet. So given that many people don't want to engage in MAT, and given that substance use disorders are evolving and chronic diseases, we really need to have diverse interventions to prevent relapse, comparable to other chronic illnesses. So just a few definitions to help put us in the right frame of reference and get us all on the same page. I did just want to review lapse and relapse. For the most part, these words are used among people in recovery and, just a lot of people in the world. They're used interchangeably. There are differences. So lapse is that initial return to the problematic behavior the individual is seeking to change. Note, this definition does not include an abstinent approach. So it's not saying that lapse is the initial return to drug use. It's lapse is the initial return to the problematic behavior the individual is seeking to change. So if that patient or person is on MAT, a lapse would be reverting back to their drug of choice in an unhealthy or illegal manner. After lapse, there's actually two options. A person who lapses can experience something called a prolapse. So that lapse was an incident, and after that incident, they reverted back to the desirable behavior, and that's called prolapse. What I will be focusing on is the alternative, which is relapse, which is the setback that occurs during the behavior change process, in which the progress of the behavior change or maintenance is disrupted by a consistent reversion back to the previous problematic behavior. So when that lapse turns into a long-term behavior change for the worse. So there are two main models of relapse that I will share with you. There's the cognitive behavioral model of relapse, and there's the dynamic model of relapse. and Marlatt worked on both of them. One was in 1985, one was in 2004. So I'll just go over a little bit about each of those. The cognitive behavioral model of relapse was designed by Marlatt and Gordon in 1985, and as you can tell by the title, it's very much based on cognitive behavioral theories. What I really like about this model is that it emphasizes the contextual factors, and it specifies that it emphasizes environmental stimuli, and that it emphasizes the internal thought processes. So those are excellent components to this model. And key components are the antecedent, so that a relapse is always preceded by an immediate high-risk situation. That's a core central part to this model. Self-efficacy and abstinence violation effect are also two very big components to this model. Self-efficacy is that sense of control someone has in being able to determine their own fate and their own surroundings. And abstinence violation effect is that loss of self-efficacy after breaking personal goals or rules. So, for me, if I am trying to study and graduate and do all of these things, I might suffer from abstinence violation effect if I don't meet some of my goals. If I don't meet some of my goals in a timely manner. All right, so this next slide just shows you what cognitive behavioral model of relapse looks like. You can see that high-risk situation always precedes whatever is going to happen next. If you go up, you see that this individual has an effective coping response. So if that person is having that high-risk situation, they have an effective coping response, they have good increased self-efficacy, they're at a lower risk of relapse than the alternative, which is if you go down from that high-risk situation. You see that person has an ineffective coping response, might have decreased self-efficacy, might have positive outcome expectancies of using the drug of choice. Maybe the person is hoping to have better emotional support from old friends, and that would be a positive outcome expectancy if they're thinking of using that drug of choice again. That initial lapse, and then after that, is it in combination with abstinence violation effect that you have an increased probability of relapse. What's great about this model is that it's very easy to understand, and I think it is very helpful for clinicians. From my public health perspective, again, I really want to know more about that high-risk situation. What's going on? Are there any trends in those high-risk situations that prompt people to relapse or lapse initially? Again, this was made in 1985. About 20 years later, the dynamic model of relapse was created to kind of update the model. Basically, it was determined that the previous model was a little bit too linear, and that relapse is a little bit more complicated than that. So a less linear model was created, has the exact same components, just added to it. So there are now, in addition to what we just reviewed, tonic processes and phasic responses. Tonic processes are distal risk predispositions that raise a person's risk for lapse or relapse. So that includes, according to the model, personality, genetics, family, relationships, and the phasic responses are also included, and those are more proximal factors that serve to prevent lapse or relapse. And that's more cognitive processes such as cravings, moods, temporary changes, and outcome expectancies. So this next slide shows you what the dynamic model of relapse looks like. It is definitely less linear and more phasic and very encompassing. Perhaps a little bit more difficult to grasp than the first one, but very helpful, again, especially for clinicians. And from my perspective, still really, I want to know more about what those risk factors are, those high-risk situations. I want to know everything going on in that big sphere of those contextual factors. What is going on, and what can public health professionals do to reduce risk for a growing population of people living in recovery? So I'm not alone in wondering, what are those things? What are those risk factors? Many scholars do believe that there should be more of an emphasis outside of the intrapersonal determinants of relapse. And intrapersonal really means individual determinants of relapse. And despite referencing social determinants and wide-scale interventions, identified determinants still mainly encompass intrapersonal and interpersonal determinants. And that makes sense. You know, we're treating it as a healthcare, a chronic health issue. We do want to focus on the individual and help them recover in a way that makes sense to them and help them improve their own behaviors. But what's missing, again, from my perspective, is that public health approach. What are the wide-scale interventions? What are the things that we can do to make our communities more robust, resilient, and healthy? So I conducted a literature review, a systematic literature review, to better understand what those risk factors are in the communities, and maybe one of those or several of those would be relevant to our community in Pasco County, Florida. And so I based this literature review on the socioecological model. There are several key components to the socioecological model. It is a great model. The main tenet is that behavioral change is influenced by altering risk and protective factors within several domains. And you can see at that bottom right, this is an image of the socioecological model where you have these several different domains of intervention. You have the individual, which is also called the intrapersonal, and that really focuses on knowledge, attitudes, and skills. You have the interpersonal realm or domain, which really focuses on family, friends, and social networks. You have the organizational sphere, which focuses on organizations, social institutions. So this could be employers, this could be churches, this could be any agency or organization that might have risk or protective factors. And you have the community domain, which is the relationships among organizations, perhaps access, might be cultural, might be transportation-wise. So community risk and protective factors are in that realm, and then public policy. So any policies that might influence health. So to kind of go along with our diabetes or heart disease example, organizational risk factors might be that the timetable or the schedule of employees is very strict, and people must sit at their desk from 9 to 5, take minimal breaks, which is not good for a person with diabetes. Obviously, they need to move more, they need to exercise more, and sitting, for that long of time is probably not ideal. A community issue might be that, that person doesn't have access to a gym or safe, free spaces to exercise, work, play. And then the public policies might be that there are really intense 59-cent big gulp sugary drinks, and the healthier options are less affordable, or that there are incentives to have food deserts or subsidies that are really propelling unhealthy options into our communities. So the socioecological model just gives us a context to be able to dissect a problem at all these different levels and better understand what those factors are so that we can then change them. So one of the tenets is that behavioral change is influenced by all of these different risk and protective factors within these different domains. But then the other tenet to this model is that by better understanding where those risk factors are, we as communities and people living and working in these organizations can change those realms. So if we know the risk factors originate in organizational sphere, we can influence that and improve health. If we know that the community risk factors are the most important, that community realm is influencing us, but we can influence it. So that is the tenet of the socioecological model and kind of the way that I look at relapse and how I was conducting this literature review. For people in prevention, in Florida, we use and across the United States, we use the word environmental factors a lot to really mean those organizational, community, and public policy interventions, risk factors, and protective factors. So when I'm saying environmental risk factors, I am not actually talking about smog or water quality, really talking about the organizational, community, and public policy risk and protective factors for relapse. So going on into the literature review, I did a PRISMA protocol, which is the preferred reporting items for systematic reviews and meta-analyses. I reviewed several different databases, PubMed, Web of Science, Scopus, PsycInfo. And I looked for a lot of keywords. So as you can all probably tell, there are a lot of different terms that are used to describe a lot of the same topics. So there's substance use disorders. A lot of the times, articles that should include substance use disorders are really only picked up if you use the word addiction specifically, substance abuse, dependence, recovery, remission. I thought of several, this is not all of the keywords, these are just some of them, but thought of as many keywords as possible that encompassed these topics and searched very hard to find those environmental risk factors for relapse. I did have several exclusion criteria. First and foremost, I limited this study, this literature review for the last 10 years. So I did this part of the study in 2018. So I backdated to 2008 to review specifically these topics, because environmental risk factors are ever changing. If we're talking about policies and we're talking about community and culture and organizational risk factors, those all change over time. So environmental risk factors that occurred in 1950 might not be the same as the environmental risk factors occurring now in 2019. So I really wanted to limit it to just what's going on now in these last 10 years during the new opioid crisis with pill mills and heroin and fentanyl. What are the what are the contexts for this? What are the environmental risk factors in this era of our public policies from 2008 to 2019? And I also did exclude anything that was related to medication-assisted treatment, and there are a few reasons for that. Namely, there is quite a bit of literature already out there about medication-assisted treatment being a very efficacious way to prevent relapse. And again, like I mentioned before, medication-assisted treatment isn't available for everybody, and several people may never want to engage in it. So I'm very curious on what we can do as communities to help people for whom this is not necessarily an option. So again, and I didn't want to dilute the results with a lot of MAT data that we're already pretty familiar with and are accustomed to and know well. So those were the exclusion criteria. After searching all these different journals and web bases, I did identify 165 potential records. After those records were removed, there were 110. I screened those 110 articles for their applicability to be included in the literature review, the systematic review. And then there was, based on the exclusion criteria, only was able to fully read the 26 that you see there. And after reading them, had to eliminate 10 because they weren't necessarily relevant. Another part of this that I didn't mention on the previous slide is that I only reviewed studies. So I did not review commentaries. I did not review, basically commentaries or papers on theories that weren't tested. So I really was just looking at tested research studies about the environmental risk factors for relapse. And again, I structured this literature review to identify primarily those environmental risk factors. So what are the policy, community, and organizational risk factors? And even though I did that, and I only found 16 articles, I still didn't find a whole lot of information about those environmental risk factors. As you can see on this slide, still the majority of the articles trended on the intrapersonal side. So very interesting, there were only 3 articles that referenced a public policy risk factor or protective factor. As you can see, there's not a whole lot in that community realm, a good bit more in organizational. So it's very interesting that even though I tried my hardest to find those environmental risk factors, even those articles that included them were very heavy on that intrapersonal level. So a few gaps in literature that I've noticed from this point is that only 2 studies had data which spanned all domains of the socio-ecological model, and only 3 studies concluded that policy level factors influenced relapse and listed specific policies. And those policies were lack of funding for housing, restrictive ID card laws for people, and state regulations ensuring sobriety. So just a few things that are very interesting about that. There wasn't a lot of information, obviously, about that public policy, but also not all of it was American. So going on in gaps from literature review, just a few things that I've noticed was that there is a need for diverse research methods. Only 2 of the 16 studies were qualitative published studies. There's a need to research risks at different levels of recovery. Most of the articles focused on short-term recovery, so that 30-day period as opposed to perhaps 12 months or after 12 months. There's definitely more need for research on the topic, and there's more need for research to be conducted in the United States. So again, there were only 3 studies that were in the United States with the United States population. And, again, these environmental risk factors are very much determined on policies and culture, organizations, and all of those are very specific to what's going on in our local communities, our country, our states. So a little bit about the results from this literature review. There were a few things that I think all of us would agree on would probably be risk factors, such as lack of access to aftercare. So several the results in this study for those that included those environmental risk factors were lack of access to aftercare, that stigma was referenced several times in that community realm, lack of access to jobs, good paying jobs came up and very many times, which is why when we look at this slide, you see the organizational level so high. There's lack of access to jobs, or there's policies in place to restrict people in recovery with criminal records from those jobs. Neighborhood security came up several times in that community realm. So studies identifying that neighborhood security and safety is related to relapse as a risk factor. So those were just some of the things that came up the most often in that organizational, community, and policy risk factor as they pertained to the United States. And then several other things for other countries, like ID laws that were specific to Chinese policies. So this all actually concludes that first part of the presentation that I was describing, where we went through a little bit of the background, had a good context for the upstream, downstream story. So as you can probably guess, after our break, I will cover going into the significance of this study that I conducted, which from my perspective, it is of paramount importance to focus more attention on successfully intervening and preventing relapse from a public health perspective. And by doing so, I firmly believe, and from the research that I've done, know that it influences and informs behavioral health policy and practice as well. In order to do that, we have to understand the environmental risk factors a little bit better that influence relapse. So I am now going to break for about 5 minutes. The second part of the presentation is a bit longer, as that is going to dive into more of that information about what the risk factors are that I found and how they might be applicable for all of you. So I actually am going to try and turn this back over to Diane, because I don't know how to necessarily break or pause. So Diane?
Hello, everyone. Welcome back to today's webinar. Monica, if you're ready, I'll turn the presentation back over to you.
Sure. All right. So welcome back, everybody. Again, I'm very excited that you're all here to learn more about this topic. So again, we basically just went through the scope of the problem. Obviously, relapse is a really big concern for us working in the fields, both prevention and behavioral health. And so from my perspective, trying to figure out what those environmental risk factors are so that we can create those strategies to prevent those risks from happening to begin with. So again, the significance of this study is that it is important to begin focusing attention on successfully intervening and preventing relapse. And in order to do so, we must first better understand those environmental risk factors that influence relapse. So again, just to review, the scope of the problem is that given that not all people will want to engage in medication-assisted treatment, and given that MAT is not available for all substance use disorders, depending on the substance, and given that substance use disorders are evolving chronic diseases, we must have diverse interventions to prevent relapse. So the purpose of the study I conducted, and it won't let me scroll, there we go. The purpose of the study that I conducted was to identify the environmental risk factors for substance use disorder relapse, specifically within the microcosm of Pasco County, Florida. So again, the environmental risk factors are organizational, community, and public policy risk factors that you can see here in the socioecological model image. And I focused specifically on Pasco County, Florida, because that's the area in which I could have the greatest impact with these results. So this was an approach, a research approach called transformative research. So the goal is always to take the information that we can and apply it to our local communities. So I'm hoping that this is a replicable study for practitioners in both public health and behavioral health who want to learn a little bit more about their local conditions and their communities so that they can address their greatest risk factors. And I'm happy to share more detailed methodology with everybody than what this study or what this webinar will go into. But yeah, so I chose Pasco County, Florida. I could have chosen Tampa Bay. I could have chosen Circuit 6. I could have chosen the Central Florida Behavioral Health Network region. But again, Pasco County was really where we could have the greatest influence, and conditions were really excellent for us to be able to dive in very deep to understand those local conditions. So the question was, what are the environmental risk factors related to relapse among Pasco County residents living in recovery from substance use disorders? So for those of you around the state who aren't sure where Pasco County is, that's where we are. We were on live PD for 3 years, so that's where we are. There was a secondary question to the study, which was to identify what the differences were in those environmental risk factors between people who lapsed after 1 year and those who lapsed within 1 year. And that question was really added from my doctoral committee, who are very passionate about better understanding the risk factors and quality of life among people who lapse after 1 year or, after that 12-month mark. So we will explore that as well. So scope of the local problem in Pasco County, this number isn't entirely correct. It's actually about 32,000 people, adults, have a substance use disorder within Pasco County, and that is estimated from data and statistics within the 2017 NSDUH report by SAMHSA. So pretty big scope of a problem, that many people with substance use disorders. Substance use disorders are linked with the top causes of death in Pasco County, as they are probably as well for several other counties in the state. It's not obvious, when we're communicating with other community health leaders, because you don't see overdose in the top 10 causes of death, but you do see unintentional injury death, as number 4. And according to the CDC, unintended injury deaths the number one cause of those now are overdoses, and, surpassing accidental death or surpassing automobile accidents. So substance use disorders are all over the top 10 causes of death. So feel free to go to Florida Charts, find your county, and really explore what those top 10 causes of death are, because substance use disorders probably influence about 5 of them, if not more. And as of last year's county health rankings, 2017 and 2018, Pasco County had the 5th highest drug overdose mortality rate out of all 67 counties in the state of Florida. So very pressing issue, very important issue. I will say that the new county health rankings that just came out have us down to the 10th highest drug overdose mortality rate. So we are very excited that we are hopefully making good and sustained progress in that battle. So to review the study methods, this was an exploratory qualitative study. It was IRB exempt, Institutional Review Board exempt, and the purpose was to identify those environmental risk factors. So policy risk factors, community risk factors, and organizational risk factors. And the way that I identified those risk factors was through recorded semi-structured interviews, basically asking a set list of questions to individuals we recruited into the study and kind of letting the conversation flow. So I didn't cut anybody off or necessarily drill home, certain questions. You ask set questions and see where the conversation goes and gather that data as it progresses organically. The questions were all open-ended and they span several different topics. So I asked about their personal experiences with relapse and their experiences just prior to relapse. I asked them what their most significant roadblocks were in their personal life. I asked them what the most significant roadblocks were for people living in recovery in Pasco County. And then I asked them what their emotions were just prior to lapse. And the shortest interview lasted about 29 minutes, and the longest lasted about 30 minutes. I recruited a purposive sample, really trying to find the right people for this study. So people who participated in this study must have lapsed at least once. They must have been in recovery for more than 1 year, and that's really for their own health and well-being benefit. They must live or have lived in Pasco County, Florida for more than 1 year of time while living in recovery. And the recovery status and the lapses that they were discussing must not have included any MAT medications. So again, that's largely because, wanting to understand what people in recovery need when they're not on MAT, for whom that's not a feasible option. We recruited our participants with the help of a really amazing recovery committee. I would like to give a very warm thank you to our recovery committee in Pasco County, especially Cesar Rodriguez, Kelly Rodriguez, Tony Reynolds, and Rachel Starriston, who really helped with the origination of this project. So just a little bit about that here. The recovery committee within Pasco County started within the Prevention Coalition, the Alliance for Substance Abuse Prevention. By working with that coalition, community members realized over time, we can't just focus on primary prevention. And so we needed to work on how to get people into treatment in order to heal our communities and reduce risk factors. And after that, we realized we need to help figure out a way that our community can prevent relapse. And so at each stage, that coalition would start to recruit new people into it. And the recovery committee was created based on that premise that we needed to better understand the community in order to prevent relapse, and we need to change those community factors. So the recovery committee was made about 3 years ago, and they really helped create this topic and this study. So they obviously had a huge hand in helping recruit the people for the study. So people in recovery and hired peer support specialists, trained peer support specialists helped recruit for the study. I met with the individuals who expressed interest in the study. I explained the purpose, obtained the written consent to participate in the recorded interview. In total, we had 17 participants, which is pretty good for a qualitative research study. A good standard is to have about 12 participants. That's a standard number really identified through a hallmark research study by Guest et al. In 2008. So that you really want as many people until you reach saturation. So if you are trying to replicate this kind of study in your own community, you might not need 17 people. A good standard is 12, but you could probably have a little less than that if you reach saturation early. We had 10 women and 7 men, ages 25 to 60. The number of lapses ranged 1 to 40, with a median of 3. What was interesting about all of the participants was that they all used multiple substances. So I screened all of them just prior to the semi-structured interview questions and asked them what their drugs of choice were. And not one of the participants mentioned only one drug. They mentioned several different drugs. 12 did state that an opioid was a drug of choice. 13 of the 17 mentioned a drug of choice that does not have a corresponding medication-assisted treatment. So that was very compelling and interesting to me. 10 had a lapse after 1 year of abstinence, and 13 had a lapse within 1 year of abstinence. So obviously we had 17 participants, so some participants only had an experience in which they lapsed after a year. Some participants only had the experience of lapsing before 1 year of recovery, of abstinence-based recovery, and a few had experiences with both. So I asked each participant about their experiences, depending on their, what experiences they had. For data analysis, I transcribed all of the audio recordings. Audio recordings were stored on a password-protected computer and then transcribed using the Trint software. After that, used the Max2DA software to facilitate the framework analysis. And the framework analysis was based on the socioecological model, from which I used the theory at a glance definitions to really spearhead and help identify which segments of the interviews belonged into which domain, and use the theory at a glance to really help with the coding process. After coding was completed, I split the responses according to length of time in recovery. So again, better understanding lapse before 1 year and after 1 year of drug use abstinence. All right, so some of the results. So I will review the environmental roadblock results, so the organizational, community, and public policy. I do have several different results for the interpersonal and individual spheres as well, and I'm happy to share that with you. But when I practiced this webinar, I didn't have enough time to go through it. So if any of you are interested in that, I am happy to share that information. So for the environmental roadblocks, I had 6 participants identify roadblocks that were policy-oriented that influenced relapse. I had 17, all 17 of the participants identified community roadblocks as risk factors just prior to lapse, and 12 participants identified organizational roadblocks that influenced lapse or relapse. So, so that is just a big overview. Those coded segment numbers, that's how many times there was something that was said that was coded within that sphere. So as you can see, participants had a lot to say about community roadblocks. And I will now go into detail about each realm or each domain and what was discussed and uncovered. So within policy roadblocks, we had several different themes emerge. There were industry regulation, health insurance, and felony charges. So within that industry regulation, only one person mentioned that as being part of a risk just preceding lapse, And that was largely about the drug industry around that person's living area, the accessibility and pervasiveness of bars and stores in that specific area. Health insurance was mentioned by 3 participants. So not having access to health insurance, not being able to seek care when they felt that they might have been at risk, or just the stress of not being able to address a health condition really contributed to the experience, the high-risk situation just prior to lapse. So again, this isn't about lack of health insurance and getting treatment. This is lack of health insurance of maybe seeking counseling because they feel like they're at risk for relapse, or lack of health insurance that they have something they need to address and they can't, and that's very harmful to them emotionally and really adds to their high-risk situation. There was a lot said about felony charges, but only 4 participants shared that information. Again, there's 17 participants. Only 4 really mentioned this felony charges, but it is of important note that only 6 of the participants had felony records. So among those felony charges, several things came up, from jobs to housing, driver's license, higher education, and court costs. I'm just going to go over those a little bit each. Obviously, people who have felonies have a hard time getting jobs. We do know that, and that most certainly adds to the overall stress of their life situation, and was identified as being part of the reason that they lapsed. Lack of housing. This was brought up several times that with a felony record, it is very difficult to rent an apartment or a house. You can buy a house with a felony record. You can be approved for a loan to buy a house from a bank, but you are unable to rent with a felony record, which really limits options of where they could live. And a few people did express that they were staying in very unhealthy relationships, very unhealthy living conditions with people who might have been using or really added to their overall stress, and that was a large reason for their lapse. Lack of driver's license was mentioned the most often and was mentioned by all of the participants as being a barrier to driving, a barrier to going to 12-step, a barrier to being able to obtain a job, a barrier to getting past background screening checks. So just a lot of reasons driver's licenses were very important and identified as a main contributor to the life circumstances just prior to lapse. One participant did mention that higher education was very difficult for people in recovery and trying to better themselves, and that it's so critical for people to be able to participate in higher education to get out of some of their jobs, and that fact that person couldn't do that or that people can't do that is a contributing factor. And then the court costs. Of course, there are many court costs affiliated with those felony charges, and that was perceived to be a lot of stress for people and really limiting of what they're able to do in other aspects of their lives. So just one quote to really demonstrate this area. "I can't get out of hospitality, and I'm struggling to get my license back, and no one will give me a home to live in. So I have to live with my parents." It was just literally like a cumulative of those things. And prior to relapse, that was just like, you know what, maybe a drink will make everything better. So this is a quote directly explaining the life circumstances just prior to that lapse that this person took. Moving on into the community roadblocks, again, this was the one that of the environmental risk factors that every member who participated referenced as being a big barrier. So there were 17 participants that mentioned it with 90 coded segments. The probation risk factors were expressed at length, very, very detailed, very compelling information, which I'll go into detail with you. And there was also some recovery support services that were identified, the providers of those recovery support services specifically. Stigma was not actually referenced. Nope. Did I skip? I'm so sorry. Hold on one second. I am at the organizational. Yeah, I want to be, I'm so sorry. I don't know how that happened. I would like to be at the community roadblocks, and I was all the way down at the organizational. So I'm sorry, everybody, just trying to see if you're paying attention and if you're lively. So moving on to community roadblocks, now that we've finished with the policy, community roadblocks, we had easy access to drugs, where we had 14 participants mention that easy access to drugs was a big contributing factor to lapse. This code includes both the illegal and legal access to drugs. So for the legal access, very much being surrounded by shops, stores where it was very accessible for them. Illegal access might have been that they lived in a house of illegal activity, or they knew exactly where the drug dealers were in their area. So easy access to drugs was the most commonly referenced concept, risk factor in the community domain. Drug use culture was referenced several times by 3 people. So the very interesting drug use culture that I noticed was actually one of them was referenced within a 12-step. So drug use culture was referenced as a community as a whole, that it was hard for people in recovery to find networks, to identify with people, to build relationships when drug use culture was so prominent. And for one particular participant who lapsed just because there was a drug use culture within the 12-step, and that 12-step group was with that person and they were using, and that was her lapse. So very important, drug use culture. Stigma came up several times, 7 participants, 11 coded segments. What is fascinating about stigma as well is that several of them, 70% of the participants who mentioned stigma were referencing stigma within a 12-step. So saying that they didn't feel like they belonged, they felt like their 12-step was cliquey, they didn't feel good enough, that they weren't encompassing of mental health. So stigma referenced a lot, and that was also referenced in previous literature, but by asking people in recovery, a little bit more about that stigma, it became very obvious. It was very much specific to 12-step communities that they felt that stigma. Moving on to lack of accessible resources. This is a general theme in the community roadblocks area and encompassed lack of employers. So just lack of jobs in general in the community for people with their skill sets or with their knowledge. They just could not find a good paying job, which really contributed to their life circumstances. Public transportation was brought up several times, that that just is not accessible to get around the county or get around the Tampa Bay area. Treatment aftercare was also brought up, similar to the previous studies that was in the literature review. Housing, of course, came up, and as did 12-step. So 12-step really spanned across this whole area through all of these different codes and these different themes within the community roadblocks. So we have everything from, lapse happened because people couldn't access a good 12-step. They couldn't access it because they just couldn't, they didn't live near one, or, transportation wise, they couldn't get to one. So there was that. So several people mentioned they just didn't have access to a 12-step. And then other people mentioned they had access to 12-step, but it was not a good 12-step. They felt isolated. It kind of backfired, had the opposite effect of what we would have hoped, as practitioners, either because that 12-step had drug use happening, which influenced individuals, or because of that stigma. So a very good and a good sign is that people identify they need 12-step and that support, but they're having a lot of issues accessing it for different reasons. And a quote for this one is, "I thought that I would relapse on alcohol faster because it's more readily available and I drank every single day. And like I was in an apartment complex where, one of my relapses, I found a pill on the washer of the laundry room. Oh, yeah, washer of the laundry room. Like, who finds a pill and then just takes it off the laundry? But who leaves it?" But so that's what I was surrounded by. So you can see through this quote what the lived experiences of people who are trying to live in their recovery, but being surrounded by drug use and how that works against them. And, within the idea and within the framework that what can we do about it to try and prevent those risk factors. Now we're going into the organizational roadblocks. So organizational roadblocks had 12 participants reference risk factors with 34 coded segments. And these were split into the following categories: probation, recovery support service providers, not stigma. I do apologize, that is a remnant from the previous slide that wasn't deleted, and then workplaces. So within here, we have probation, where we had 5 participants mention that probation was an overwhelming contributing factor to lapse. 83% of participants who had felonies mentioned probation as being a big factor. There was a lot of really in-depth information about why it was so difficult. Participants mentioned that it was difficult to find and keep a job when having such diverse expectations, that there were either stressful or insignificant rules they felt within the probation office that made it very difficult for them to stay in compliance. So we had one person specifically mentioned that her probation officer advised her to stay put during a hurricane where she had to evacuate her family because she lived in a flood zone. So that's just a quality feedback for that probation office. That probation officer might not have known, but basically that person felt that they could not leave their house. They sent their family away. They stayed in that house. The whole area flooded, and after a few days, that person eventually went to a different home of a friend, and that lapse happened very shortly after. Another person referenced a different probation experience where they violated their probation in what they perceived to be a very minor way. And knowing that they violated it, knew they had a warrant for their arrest, and before turning him or herself in, decided to, well, if I'm going to turn myself in, I might as well use my drug of choice. So probation came up a lot. There was a lot of feedback on how difficult it is to be able to get a good paying job that respects the fact that you might have to leave for color code. So, at the drop of a hat. So it came up several times. Recovery support service providers, that was feedback of 2 participants who felt that they weren't prepared well, or that there were operations within those recovery support specialist providers that had a negative impact on them just prior to lapse. And then workplaces, there were several different subcodes within that theme: hiring procedures, culture, and scheduling for people, who are trying to work, while being in recovery. They found the culture to be very isolating a lot of the time. So a lot of people who work in a service industry or who work in a trade were often surrounded by that drug use, but they might not have necessarily been able to leave that job. There were scheduling issues. So several people mentioned that they felt that they could not get to their 12-step meetings, or they couldn't prioritize their family well-being or recovery because they had to drive an hour and a half to work. And then they had a 9-hour workday, and they had several other things making it difficult for them. Sorry, I don't know why I had advanced just now. There we go. Yes, so scheduling proved to be difficult, and then hiring procedures also made it difficult for some people to get a foot in the door with some of those workplaces. So it was mentioned that automatic applications. So online applications really worked against many people because they knew, as well as they knew their name, that they weren't going to be able to explain adequately on an automated system why they had a gap in their work record. And they don't look compelling on paper, but they felt that if they just had the ability to meet with managers or store owners in person, that they would have had a different experience. So just a quote from this portion, organizational roadblocks. I kept working alongside people that were using and drinking, but I was a server. And so I was surrounded by it. Okay, so now for a little bit more of the macro level. So that was going a little bit in the weeds on some of the what was shared. I do have another quote before I go into this slide. It's not on this webinar, but I'll read it to you. It says, at that point, I thought it was impossible for me to get a license back. And there were jobs that I could have had if I had a license, but I didn't. None of these were good jobs, but I would have taken anything at that point. I think the job thing and the relationship thing were the two biggest factors that played into me making the first turn to go into that bar instead of to continue looking. Not being able to find a job, being told no over and over again will put you back in your old ways faster than anything else. When you are trying your hardest to do the right thing and everything is butting against you and everybody's telling you no, it just makes you want to give up. And I share that quote just prior to this slide because there are several different community-wide risk factors, environmental risk factors identified in that quote, from not being able to get a job because that person was a felon, not having accessible community resources, and being told no, probation issues, you name it. This quote really encompasses a lot of that. So when we look macro at the collated data, the 17 participants all together, we see where there are clumps of emphasis. So of the 17 participants, as you can see, the most of them mentioned that lack of accessible resources was the most important, or the most referenced contributing factor to their lapse. There's also easy access to drugs and a little bit on the felony charges and workplaces. Then I split the responses. I asked the participants, what were the most significant issues among people living in recovery in Pasco County, and what were the most significant issues in recovery for yourself, personally? And their responses were different. For people, when I asked the question, what was the main reason? What were the main risk factors? What was going on in your life just prior to lapse? They all said, every single one of them said, the biggest barrier was myself. The biggest barrier was me. It was me. It was my mind. I didn't have the resolve, whatever it was. They took that full ownership. I think that was the number one reason. But when I asked them what are the main roadblocks, what are the main reasons, what are the main risk factors for relapse or lapse among people living in Pasco, they said it was the community-wide roadblocks. So I found that fascinating. A really strong culture within the 12-step groups and within people who are living in recovery in an abstinence-based way. Is that they do take that ownership, but they can identify the risk factors when you ask it on behalf of other people. This is very telling. All right, so this is some of the most compelling information from this study. Really starts in this by splitting up the information according to lapse after 1 year and lapse within 1 year. So this is a little difficult to see, but basically what's happening here is that lapse after 1 year, people who had lapse after 1 year referenced more roadblocks within that intrapersonal, so that individual area, more than anywhere else. Kind of hard to see. I do want to explain that this slide, we had less people who had lapse after 1 year. than lapse within 1 year. And this image compares the two groups against each other, so it's a little skewed. I have another slide that explains it a little bit better. But basically, for people who lapsed after 1 year, they had more identified risk factors in the intrapersonal level. And people who lapsed within 1 year had more going on within that community-wide roadblock realm. And if you split that up even more detailed, this is a slide that shows you the broad codes, the broad themes, and then the sub-themes and sub-codes under which we were able to identify and, I guess, code the data. So for people who lapsed after 1 year, you can see it's pretty even Steven up and down in the column. Each dot represents that at least one person stated that issue was a precursor to lapse So the bigger the dot, the more people referenced it. So again, you see in that left column that for people who lapsed after 1 year, they didn't have a whole lot to say on the community-wide risk factors for that lapse. When you look at the lapse within 1 year, people who lapsed within 1 year, they had many more people mentioned easy access to drugs, transportation, workplace culture. So more people reference those outside, those environmental risk factors as being precursors to lapse. When you look at the individual and interpersonal realms, you can learn a little bit more as well. So for people who lapsed after 1 year, the large majority of that group, that subgroup, mentioned that the risk factors prior to their lapse was individual. It was their lack of knowledge of their own disease. As you saw in the previous slide, they felt it had very little to do with those environmental risk factors and had everything to do with their knowledge or lack thereof knowledge of their disease. And I want to dive into that a little bit. Most of these participants, 8 out of 10 of them, mentioned that what they called delusional thinking, that they felt that they had recovered, that they felt that they were fine, they felt that they could drink like anybody else, they felt that they could, their drug of choice was alcohol and wasn't opioids, so perhaps they can have an opioid, or their drug of choice was meth, and maybe they can drink alcohol like their friends, and they can do what everyone else can do and not have the repercussions they had before because they have it all under control. So that is the majority of what people said about their experience lapsing when that lapse occurred after 1 year of drug use abstinence. When we look at lapse within 1 year, we see a much less emphasis on the knowledge of their disease. It was much more about not having good relationships, not having relationships that were living the lifestyle that they're living, and some medical conditions. So for some people, they were recently in recovery and had to have surgery, and how did that influence their recovery? As you might remember, one of the things that I asked everybody was what their emotions were just prior to lapse. And this is a word cloud that demonstrates what everyone was feeling just prior to lapse. Shame came up the most often, which is why it is the biggest. The smaller the word, the less often it was referenced. So you can see that stress is there. There's the word stress, and off to the right, there's the word stressed. There's pity, there's alone, there's pissed, deflating. But the big takeaways here are that the most commonly referenced emotions were overwhelmed, shame, and guilt, with the biggest being shame and guilt. And I find that very interesting and very telling because all of these people we recruited into the study had been in recovery for at least 1 year. And their emotions prior to lapse were still shame and guilt. Working with the recovery committee, I had expected that I would hear emotions of shame and guilt prior to seeking treatment, I hadn't necessarily expected to hear it that much prior to their lapse. They felt shamed that they couldn't get a job. They felt shamed that they had to walk 1.5 miles to get their kids from school. They felt guilty that they couldn't meet the requirements of their employer while managing and juggling the management or the requirements of their probation. They felt overwhelmed that they couldn't navigate the systems and they needed to improve their emotional support network and didn't know how to do it, didn't have the skill set to do it. So shame, guilt, and overwhelmed were the feelings just prior to lapse. Again, also interesting because a lot of the relapse literature emphasizes stress as being a precursor, which did come up several times, but not as much as shame and overwhelm. All right, moving on into these conclusions. So there is a lot of information from the study and the previous study. 10 broad roadblocks were identified within the socioecological model from this study. The community domain had the most roadblocks. Issues ranged from finding housing, jobs, 12-step fellowships, most commonly referenced and pressing issues for people living in recovery in Pasco County. Probation was a leading issue for people with felonies. So very good, very telling. Even though it was only referenced by, those 4 people or those 5 people, there was just such a wealth of information for that subpopulation. Of course, not everyone living in recovery has to go through probation offices, but for those that do, their feedback was consistent. People who lapse after 1 year have very different experiences than those who lapse within 1 year. So like I had expressed before, people who lapsed after 1 year really struggled understanding their illness versus struggling with stabilizing and integrating in the community for those who lapsed within that 1 year. So overwhelmingly, people who lapsed within 1 year just couldn't figure out how to integrate in a way that was stable. And of course, the emotions of people just before lapse was that burden of shame. So some strengths of this study before going on into implications and ideas for implementation is that the study was very innovative. This is a very hard to reach population. This is, they call it Alcoholics Anonymous for a reason, because until recently, our culture has been, we wanted to remain anonymous, very, very stigmatized. We are very fortunate in our community to be able to tap into people who were on the leading edge of this recovery movement, this RCO movement, and are able to share insights and gain the trust of other people in recovery to share their insight. It's very exciting, very great strength of this study. The other great strength of this study is that it has the ability to influence the local conditions and shape community investments, shape the way that perhaps behavioral health providers want to consider either new practices or revisit some old ones. We'll go through that in a little bit. And then the other strength of this that's not on this slide is that this is actually incredibly replicable. So again, if there are any of you who are on the webinar who would like to investigate what your environmental risk factors are for lapse, I can share with you the code books that I use, the semi-structured interviews that I use so that you can recruit and ask those questions so that you can figure out what those risks are and you can work with your communities to make them more resilient. Some limitations are that this is not incredibly generalizable. We had a good sample size for a qualitative study, but given the fact that environmental risk factors are very much dependent on local conditions, this isn't going to be generalizable necessarily to other states. For example, we said health insurance was an issue among a few participants. Health insurance might not be an issue in states that expanded Medicaid. There are issues related to felonies that might not be experienced in states that have worked on a lot of defelonization policies, or states that have worked on and passed driver license policies so that people can keep their driver's license or get them back quicker. So a lot of this won't be generalizable to outside states, but within Florida, a lot of this will be relevant to your local communities. Another limitation is there is a bit of researcher bias. As a doctoral student, I was the only one really looking at this. I did my best to account for that researcher bias and put a lot of tests and secondary tests in place to make sure that I was coding everything properly. I did constant comparison techniques several times. So, but there is that element that there is that potential that I coded things in ways that I expected to hear. A careful and important observation of this study, I only coded what people said, not what the responses, not what the interventions could be. So if somebody mentioned that they could not access jobs, they didn't have enough access to work, I coded that in the community realm because there weren't enough, there was a lack of employers. It doesn't matter if there is a policy solution. I wouldn't code it based on the possible solution. I coded it based on what they said. So there was actually probably a lot more information that I could have shared and analyzed, but I only based it off of what they said, which is very limiting based on the fact that they might not know a whole lot about different policies that affect them. Whereas policy specialists might be able to identify tax policies or, different rules and regulations that affect people in recovery. People in recovery, for the most part, didn't say policies were a big issue unless it was related to their felony, because that's what they knew, that's what they experienced, and that's what they said. One of the biggest limitations of this study is that it was only 12-step centered. So I did not anticipate that. I didn't necessarily expect that or try for that. I did want to recruit only people who were abstinence-based in their recovery, since I feel like that might be very different than MAT-based recovery and roadblocks. But it was only 12-step, and they didn't mention any other group-based therapy or just group support systems. So very 12-step centered, which has a different culture than other group support groups. And it was abstinence-based only group, which I do think is also a strength since it is an understudied population. Some implications for this population: the majority of the participants used multiple substances. All of the participants used multiple substances, with 13 of the participants had a drug of choice that does not include a medication-assisted treatment. This really emphasizes the concept that we must have diverse interventions to prevent relapse, that, we really look at medication-assisted treatment and its science in high regard, as we should. But if a person has an opioid use disorder, but their drug of choice is meth, that MAT might not be relevant to them in the way that it is relevant for a person whose primary drug use or drug of choice is that opioid. So it's just very, very interesting that 13 participants said that they had a drug of choice that didn't have a corresponding MAT. Results from this study will inform potential interventions that could benefit this underserved population. So some implications for public health or prevention. These results can really help us better understand how to create health in all policies. So kind of how we have a standard in our country, really, that we conduct environmental impact studies before expanding a new road. We're really on the cusp of having a standard as a nation that we should be considering health in all policies when considering new policies or new infrastructural changes. This is particularly exciting, but it's still new. It's still new concept in the field of public health, and it has a lot of opportunity to be influenced by different sectors and fields. So from my perspective, health in all policies have been studies that really focus on the more traditional chronic diseases like diabetes and even tobacco use. I think this study and information like this can really be leveraged to help community planners understand how their policies and procedures or proposed policies and procedures might influence people who are living in recovery. So perhaps before changing a transportation road, they take into account how that might very specifically, impact their rates or the lives of people living in recovery. Or if they are thinking of decreasing some agency or making changes to their probation office, how might that influence the health of their population? Where about 7% of people might be having a substance use disorder in their lifetime. How does that influence your community? How do your policies and procedures influence that population? What is the emotional burden that you face as a community? What is the economic toll that you might face as that community, and taking that into account when making those policies? So opportunities to highlight the health repercussions of policies related to violating parole, revoking licenses, and healthcare expansion. So lots of opportunities for policies and how to influence them. Perhaps the most exciting to people who love campaigns is the information garnered from the stigma part of this study. Was, we know that stigma is pervasive still to this day, and, we always talk about busting stigma busting campaigns. We do recover and stomp out stigma, and there's really great campaigns going on down south. But our participants mentioned overwhelmingly that the stigma came from their 12 steps. And they really didn't mention stigma outside of that. There was a little bit mentioned about just the cumulative feeling of being stigmatized when you can't find a job and you can't find an apartment or a place to live. But the majority of the respondents did say that the stigma came from within their 12-step group. No, I'm having a hard time advancing the slide. There we go. More implications for prevention in public health. We can work with organizations to increase access to 12-step fellowships and mutual aid support groups. So for those employers that hire people with felonies or have a high population of people who are living in recovery, we can encourage them to promote either their nearby or support groups, or we can even encourage them to co-locate their support groups. We've done this a lot with nicotine replacement therapy and addiction counseling, and it could be a promising practice for other addictions as well. So again, if there are these consistent service industries and trades organizations that hire, and we're so thankful for them to hiring, we might, as a field, want to approach them on how they can better create good policies that accommodates and puts recovery first. So recovery first centered policies. Are you flexible in when a person can leave throughout the week so that they can meet their 12 steps or their support group? Or do you have a co-located support group? Do you have good behavioral health policy in your insurance plans? All of those things are things that we could look at within that workplace organization sphere. Transportation is another thing, of course, we can look at when we have people who cannot drive and cannot navigate across the county in an accessible or get across the county in an accessible way. That is a big problem, and we might, as public health professionals, want to look into innovative ways to making sure that people have transportation access. If it is a continually large issue, this might want to be one of the things that our COs champion within a given community. So lots of different innovative ways. Might want to be able to partner with Lyft or with Uber, whatever ride-sharing app. There might be several different innovative ways that we can help meet this need. There's also just a lot of information on how to inform opportunities for improvement among different organizations and institutions. I do want to mention that even though I did mention a lot of risk factors and roadblocks for probation and behavioral health providers, not all of those behavioral health providers or institutions were in Pasco County. They really did span Tampa Bay and even down south, because as you can remember, the requirement for being in the study was that they lived in Pasco County in recovery, and can speak to the life of recovery in Pasco County. Some more implications for behavioral health. I'm very excited about how information like this could expand or add to the theoretical models of relapse. I mentioned earlier that the first model for relapse was from 1985. The second one was drafted in 2004. Those are about 20 years apart, and we're coming up on that 20-year mark coming up here in a few years. So not necessarily saying that a new model will be released, but it's always good to revisit these models and really think about what else can be added, or what makes the most sense, what do practitioners and other professionals need to know, and how do we incorporate that in a way that makes sense, that will improve continuity of care. So I think this information, although very specialized to our population in the Tampa Bay area in Florida, I think it informs and elaborates upon the antecedents and the tonic processes that we reviewed earlier in those relapse models. I think that this could also be used to influence discharge planning, continuity of care, aftercare, and policies related to funding streams related to those items, into those things. So leveraging the knowledge of peers about their local support group culture seems incredibly imperative based on the results of this study. So we saw, 12-step was so important to people. Accessing 12-step was so important, and the lack of access really influenced relapse. But equally, so did accessing not great 12-step. So really working with those peer support specialists and having them help us understand which are the 12 steps that are good, which are the 12 steps that are not good, that we should not be promoting. How do we create better 12 steps in communities or other support groups in those communities? What can we do to make sure people have the support they need and the recovery capital that they need? And we can really work with peer support specialists to help with that. Other implications for behavioral health. I think that a lot of this could, I know Ken is on this call, and I know other people within the ROC, the Recovery Care, RCO, Recovery Care Organization, and Recovery Oriented System of Care initiatives are on this call. And I think that all of these work really well together. I look at the ROSC questionnaires, and I see that we're trying to ask, if people have the right kind of community activities. Do they have access to community activities? Do they have available educational opportunities? And the answer might be no, but it might be because they're environmentally determined, that they are determined from that community realm, that organizational realm, and that policy realm. And how can we work with other professionals in other sectors to improve those conditions so that people do have access to those critical services and supports? I do think that another implication is that this could help inform long-term strategies to keep people engaged with providers. Although we have been talking about this for a long time now, that addiction and substance use disorders in general are chronic conditions similar to any other chronic illness, we do not treat it. We still don't treat it the same way. And I think everybody on this call agrees with that. A person who has cancer doesn't undergo treatment and then call it a day and not go back to their cancer specialist. You don't stop going to your cancer specialist after 3 months or after 6 months. You continually go back for checkups. You meet with specialists for a long time. So the idea that we really still handle treatment as isolated situations should probably be revisited. And that's very tricky when funding streams are the way that they are. But this is something that, if we are seeing relapse rates and relapse among people who's been in recovery for a year or more than that, we should really figure out a way to keep them engaged in services so that they know where to go, or they have an easy access when they might be crisising, or they know to expect that they might have that quote unquote delusional thinking. We might want to also emphasize that when we are discharging people, that at some point you're going to think that you don't have a problem, that you can drink like everyone else. Just remember, that's a big time for when people might lapse. Another implication is that this could inform some incidental funding. So for people who mentioned that they needed more follow-up, they were pretty specific about what they wanted. So 41% of participants in the study mentioned they wanted more treatment follow-up. They wanted reintegration services, life skills. They wanted to know how to talk to people. They wanted financial planning. They mentioned being overwhelmed, not knowing how to do these things as well as they felt that they should, and really emphasize that social skills component, that they didn't know how to talk to people while being sober or abstinent, and how to make friends and legitimate relationships. So that might be a good opportunity, those life skills, and how to maybe spend some of those incidental dollars, and also helping people find their home 12 steps. One of the best qualities from the study was when people were sharing that they really valued that their behavioral health provider took them to different 12 steps so that they could find their home 12 steps, and that they knew upon discharge that they already knew where to go, that they were given a sample, and they thought that was great. They also had the feedback that having different 12 steps coming in was also really helpful. So many implications for both behavioral health and public health. And now that we are down to the last 15 minutes, I'm just going to leave with a few departing thoughts before we open it up to questions. I do want to emphasize, treatment is so important, and obviously the purpose of this study and the work was never to say, treatment doesn't matter, let's focus on public health. It's to emphasize that we have to be looking at it holistically, and how can we improve our local conditions so that treatment can be more effective, that the world is not necessarily working against people leaving treatment. So we can continue to offer treatment, but until we better understand and fix the reasons our neighbors, our friends, our family members keep falling back into that river, we will not be fully successful. We have to fix the bridge. We have to figure out, how to remove that ice cream cart. We're doing a good job sending life preservers and getting people out of the water, but we really need to figure out how to fix that bridge so that people who do recover don't fall back into the river. And we must address all factors within the socio-ecological model: intrapersonal, interpersonal, organizational, community, and policy. And it takes a lot of time to see the effects of these changes. So I would, all of them must be addressed, and it will take a long time, but a worthwhile community-based approach will be a good and effective way to improve relapse rates. So just some next steps. So obviously these are just the risk factors, community-wide risk factors, and specifically within Tampa Bay and Pasco County. So next steps would be to design the interventions based on this information. What are we going to do with this information? Perhaps we want to approach different organizations about offering their support groups near or on site. We might want to address the stigma. We might want to, provide some feedback to the different probation offices that were referenced here, that spanned a few different circuits, and provide them that feedback. So whatever we do, this was just the first step, was identifying the risk factor. Now we design the interventions, we implement them, and we evaluate them. And hopefully we'll be able to share that information and be able to add to the practice-based knowledge and the science-based knowledge. I would also say that the next steps for this study would be to do the exact same thing with the MAT population. How do we better understand the risk factors for people with medication-assisted treatment? In all, the study did really it emphasized the data already available through literature review. It, definitely complemented the work of leading professionals in this field, especially like William White. I think it just added a little bit more of a deeper knowledge and context at a local level. We knew that stigma was probably going to come up. We didn't know how it was going to come up. We knew that accessing jobs was probably going to come up, but we had no idea necessarily the extent to which probation really fed into that. And by further understanding that in-depth knowledge, we can create better tailored projects and interventions to address those risk factors. So with that, and with 2 hours gone, thank you to the 140 of you who are on the call for 2 hours. I can now open it up to any questions that you might have. And hopefully, I believe the way that we do this is just putting that information in the Q&A box. And I'm trying to figure out how to do that. I'm not.
Hey, Monica, I can read some of the questions for
you.
you.
Thank you so much. I'm not good at the multitasking.
One of the questions that came up, can you expand on the domain of industry regulation?
Sure. So that one, let me go back to that slide. It came up not very often, and it was really specific to where that person was living. Hold on. And just the hours of operation of different stores around that area where people could go in and get really cheap liquor. And that person specifically mentioned that they didn't feel like there was enough regulation on recreational drugs, that people could just buy them at any time and that people were using, and that, so basically that not enough things were illegal in their area, or that the industry selling and promoting drugs was not restrained enough in their area, and that was considered a risk factor for their lapse. And again, that was only mentioned by one person.
Identifying an individual recovery capital, how can we focus on educating the individual in recovery on the importance of growing and using your recovery capital, reference William White recovery capital scale?
Can you repeat that question?
Identifying an individual recovery capital, and how can we focus on educating the individual in recovery on the importance of growing and using your recovery capital? And then it says in parentheses, reference William White recovery capital scale.
Okay, so I hope I understand that question. I mean, I am not a clinician. I'm a public health professional. So I'm not entirely sure what the best ways to educate individual clients on recovery capital. I'm more skilled on understanding that recovery capital isn't only an individual-based paradigm. It's not entirely up to the individual to build that capital. As community leaders, as people in, as community leaders and community designers, the onus is on us to create an environment in which recovery capital is obtainable. So I am not sure how to necessarily answer that question for the clients themselves, but I think that we can leverage William White's work and really put the call to action for different sectors in the community that we need to improve community or recovery capital from a community perspective. And this is how we do it. We look at the risk factors in this study and in other works within the last 10 years, and we focus on that. So I'm sorry, I don't think I can answer that question very well since I'm not a clinician. But I'm happy to work with clinicians to figure that out.
Okay. Next question is, I might have missed it, but I am wanting to know how you operationalized a lapse.
Yeah, that's a good question. So operational definition, right. So what I learned in this study is that the population that I was working with really used lapse and relapse interchangeably. And so even though I had these operational definitions, it got really convoluted to try and hold people to those definitions. So one of the limitations of this study is that I really based participation only on what people perceived, so I didn't collect records. I didn't look at hospital or behavioral health records to see if they actually had a diagnosable substance use disorder or if they did lapse or relapse. So it was based on their perspectives, their willingness to be in and participate in the study. So that's a pretty decent limitation as well. So the short answer to that is, I presented those definitions of lapse and relapse by Hendershot. That's what I worked with from my paradigm, but learned pretty quickly that people who were participating did not necessarily hold strict to those definitions, and I kind of just flew with it. If they felt that they lapsed, I took that as, that is their reality, and their lapse might mean relapse, or it might just mean one lapse. So just kind of went with the flow on that, to be honest.
Thank you, Monica. And just one more request. Will you review your reference pages and then we'll wrap up this webinar. Thank you.
Yep. So references. All right. Is there anything else?
I think that's it. So thank you, Monica, for your time today, and we're going to conclude this webinar. In just a second, get to my to-dos. So we are going to conclude today's webinar. Your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. And if you do not receive the evaluation before middle of today, please reach out to us and contact us via email or by phone to make sure you get access to that evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You will want to use the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be messenger@WebEx. Evaluation will close at midnight on Thursday, July 25th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. We will send you an email notifying you that the statement of credit has been posted if you have met the criteria. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.